Welcome to the Health Information and the Law Perspectives from the Field interview series. Today we are speaking with Eric Goplerud, Senior Vice President and Director of Substance Abuse, Mental Health, and Criminal Justice Studies at NORC at the University of Chicago. Welcome, Eric. Thank you so much for joining us today. Would you please tell us a little bit about your current position and how it intersects with the field of health information exchange?
Sure. I am a Senior Vice President at NORC at the University of Chicago. I direct a Department of Public Health here at NORC with responsibilities that include substance use, mental health, as well as public health research and data analysis. For more than a dozen years, I've been working to integrate substance use into good health care and substance use into health. There have been a number of very important developments that have been making that more possible. The Mental Health and Addictions Parity Act in 2008, the Affordable Care Act, the coverage of pre-existing conditions under the Affordable Care Act, the expansion of Medicaid programs and the health exchanges to cover more people who have mental illness and substance use disorders, now covered by insurance, who were in the past would only have been covered by government sources and by grants, and leading research and learning collaboratives on screening and brief intervention for risky alcohol and drug use and treatment that takes place within the healthcare setting. So as we are moving healthcare to care for the entire person, where we have insurance coverage that is covering the entire person, not excluding conditions such as substance use disorders and mental illness, health information exchange becomes absolutely critical for quality care, safe care, and efficient and valuable care, or as CMS is talking about the triple aims, at getting high value for resources expended. And the integration of people with substance use disorders or people who have comorbid substance use conditions with other medical conditions into good health care has got to be complemented by integration of data about their health utilization, about their treatment into the electronic health records.
Wonderful. Thank you so much. I think you referenced the role of substance abuse information in medical records and the importance of including that information, these medical records, as well as we move towards a more integrated healthcare system. There's been discussion around the Part 2 regulations that govern substance abuse information and medical records in particular. I'm hoping that you could briefly describe who they apply to and how they also relate to the exchange of health information.
The federal substance use privacy regulations, often referred to by the federal regulatory nomenclature of 42 CFR Part 2, covers all substance use treatment information in substance use treatment programs. Substance use treatment programs are defined by the law and by regulation as any program that holds itself out to be treating or diagnosing substance use conditions. That's alcohol, drugs, misuse of prescription drugs, and that a program that holds itself out and that also receives any federal funding is considered a Part 2 program, a program whose health records fall under the purview of the federal substance use privacy regulation. The conditions of the exchange of information, health information, in Part 2 organizations are very tightly constrained. The 42 CFR gives substantial control over the exchange of the covered record to the patient. The patient must specifically give permission for the exchange of any information from a Part 2 covered organization with any other organization, and puts very strong controls on the release of information without the explicit consent of the patient with a named organization or individual to receive the information, a description of the type of information that can be exchanged, and the length of time for which that information, that permission for exchange of information can be is valid. It also prohibits redisclosure of that information by the receiving individual or organization, and that receiving organization is required to maintain those same confidentiality and privacy controls over that information. This clearly creates difficulties in an environment of electronic health records and health information exchange, where there are extreme difficulties of identifying specific individuals by name who would be receiving information, and the opportunities and the networking of redisclosure that takes place within a health information exchange makes the exchange of 42 CFR covered information extremely difficult to the level that most health information exchanges simply do not include 42 CFR covered information within their HIE. The consequence of this is that patients who are receiving substance use treatment in a Part 2 covered substance use treatment program are likely not to have their health information, or the health information, even if they wish to have it disclosed, are likely not to have that information entered into a health information exchange or into the exchange of health records. This is only for those specific specialized substance use treatment programs that hold themselves out under the regulatory regime as providing substance use treatment services and that receive federal funds. There are large number of patients who are screened, identified as having a substance use disorder, and who are treated within primary health care, hospital emergency departments, hospital inpatient settings, and other health care delivery settings. If they are identified, diagnosed, and treated within those settings, their health information is protected by HIPAA, but HIPAA only. Those services are not covered by the 42 CFR regulations. As we are moving more and more healthcare into integrated healthcare systems, we have this very peculiar situation where a patient who is diagnosed and treated for alcohol dependence or drug dependence in a community health center their information may be relatively freely exchanged within a health information exchange or within a health system. A patient who receives the same diagnosis, who receives the same treatment in a specialized substance use treatment program, is likely not to be able to have that information exchanged at all within a healthcare system. So depending on the place, the physical location, and the license, information may or may not be exchanged. Care quality, efficiency, safety may or may not be compromised by the absence of information about a patient's health status.
That's very interesting. So it sounds like it's a location-specific issue depending upon who the Part 2 substance abuse regulations apply to, which leads us into our next question related to new technologies, health information technology in particular. There's been a greater use of electronic health records across the care continuum by a number of different providers. How are you seeing those new technologies that allow greater electronic exchange of information either helping or hindering the sharing of patient substance abuse information either in a Part 2 regulated setting or an external setting?
The growing capability of our health information systems to exchange information between providers efficiently and safely is driving the Substance Abuse and Mental Health Services Administration, or SAMHSA, to reconsider the current regulations of 42 CFR. It is the rapid expansion since ARA and ACA of electronic health records and the increasing recognition of how valuable it is to exchange information in order to improve the quality, safety, and efficiency of care that is driving SAMHSA and the federal government to re-examine the current regulations. But as we're looking at technology, I think it's helpful to kind of step back and think about what it is that we're trying to accomplish. In the Hippocratic Oath, there is a confidentiality pledge. That pledge says, "All that may come to my knowledge in the exercise of my profession or in daily commerce with men, which ought not to be spread abroad, I will keep secret and will never reveal." Now, this is a general pledge. It's not specific to addiction or the treatment of addiction. But the most revered portion of the Hippocratic Oath is, quote, "I will prescribe regimens for the good of my patients, according to my ability and my judgment, and never do harm to anyone." That would lead a physician or a healthcare provider to exchange information for patient safety and good patient care. The aim would not be to dismantle the Hippocratic Oath for people who have a substance use disorder, but to demonstrate how health teams and medical homes, with information being freely shared among healthcare teams, promotes patient health. Pointing out that there are many ways that health information systems, electronic health information systems, can be hacked, where information might be inadvertently disclosed, does not in itself create a reason that substance use records, especially substance use electronic health records, should be kept out of electronic health records or HIEs. The substance use privacy law was set up to protect people who were engaged in illegal behavior. The aim was to help people engaged in illegal activities to feel safe to come into treatment. But we in the substance use treatment field that is protected by 42 CFR Part 2 are doing a terrible job of actually getting people into treatment. About 95% of people who meet the criteria of a substance use disorder did not seek treatment or want treatment. Of the 5% who want treatment but did not get it, 4% did not want to stop using. Currently, we're treating about 2.3 million people in specialty substance use care. Perhaps 1 in 10 of the 23 to 25 million persons in America who have a substance use disorder. We're perhaps treating 1 in 10 who need and could benefit from treatment. If 42 CFR was set up to help people get into treatment, then how come it isn't working all that well?
Is that one of the critical issues that SAMHSA is working to identify as they think about modifying the Part 2 substance abuse regulations, incorporating the concept of the new technologies that are available, and of course the greater emphasis on exchanging of health information and new integrated models of care?
That's exactly one of the three areas that SAMHSA was particularly focused on in the listening sessions, which took place in early June. SAMHSA was quite concerned about how protected information under 42 CFR could be entered into health information exchanges. They were asking specifically about whether it was possible, rather than identifying on an informed consent or consent to share records, rather than identifying a specific physician or nurse or other healthcare provider, as currently is required under the current regulations, that it may be possible to identify an organization or organizations or permit disclosure into a health information exchange. They also were interested in exploring the idea of whether of the development or use of a mechanism permitted under the 42 CFR Part 2 of a qualified service organization arrangement, essentially a contract between specialty substance use treatment providers and a healthcare provider or healthcare system to provide services for patients with a substance use condition. Whether the qualified service organization agreements could be used for covering a health information exchange and a substance use treatment specialty organization. So very much they're trying to figure out how to accommodate the requirements, which are very strict in law as well as in the regulations, how to protect the privacy of patients who may be engaging in illegal behavior, or whose behavior, if exposed inadvertently without their permission, could lead to discriminatory outcomes, could lead to worse health care for them, or might be used for discrimination in employment, other forms of insurance, housing, work, employment. How to protect that sensitive information from being disclosed in a way that could harm individuals, or to prevent individuals from disclosing that they have a treatable substance use condition. They're really caught in a very difficult position because there are very good reasons to believe that in a highly stigmatized condition, in which healthcare providers often share the public prejudice against people with addictions, and consequently treat people with addictions with less empathy, with less care towards ongoing care. In fact, what we have seen instances of essentially physicians firing their patients, saying that they cannot treat them, knowing that they have an addiction. On the one hand, SAMHSA is trying to, and the government is trying to protect people from being hurt by disclosing. And on the other hand, we have many, many instances of patients who end up being medically harmed because information about their substance use condition is not available to a treating healthcare provider. I had a call a couple of months ago from a physician in Minnesota who was both at the same time furious and really sad, because he had a patient who was on methadone that he did not know and the patient did not disclose, who came in and asked for medications to treat anxiety. He gave the patient benzodiazepine, and the patient died of respiratory arrest, a preventable medical crisis. And he wanted to know, what could we do to change this? How could similar kinds of deaths be prevented? A 5 medical societies who deal with, whose responsibilities include treatment of addictions. So the American Society of Addiction Medicine, the American Academy of Addiction Psychiatry, and others, wrote a letter to SAMHSA and to the Office of National Coordinator for Health Information a couple of years ago, strongly recommending for patient safety, quality, and for efficiency that a very minimal amount of information be disclosed, or that could be disclosed into health information exchanges. That is diagnosis, medication treatment, whether the patient, dates of the patient's receipt of treatment. That's it. But they recommended that that information was essential for patient safety, patient quality of care, for continuity of care. And I think that it's really important to listen to the the health provider leadership recommending that for patient safety, quality, and care, that some minimal information can and should be included into the health record.
Before we move on to our next question, I just want to clarify for our listening audience that we've been referring to SAMHSA, which is the Substance Abuse and Mental Health Services Administration, which is an agency under the Department of Health and Human Services. So, Eric, following up on your last response and talking about the letter and the encouragement from the professional societies that is coming to SAMHSA in particular, and given the town hall that was held earlier in June, what is your sense of SAMHSA's willingness to seriously consider modifying the Part 2 substance abuse regulations to achieve the better balance in terms of integration and quality and safety of care that we've been talking about?
I think the likelihood is very, very great. The director of the Center for Substance Use Treatment, Dr. Wesley Clark, the Center for Substance Use Treatment is the one of the three centers within SAMHSA. Wesley told me that SAMHSA anticipates putting out a notification of proposed rulemaking, or essentially a modification of 42 CFR sometime later this summer, and is likely to be putting out a final rule before the end of the year. It is hard to forecast exactly what changes will be included. Clearly, there will be a period of public comment and information gathering that will take place between the time of the notification of proposed rulemaking and the final rule is published. But I suspect it'll be in the areas of disclosure of information, or the ability of a patient to give permission to an organization or to an HIE rather than to specific individuals, will allow for an indefinite length of time that information can be, records can be shared, will permit the redisclosure of information, perhaps under conditions similar to HIPAA for the purposes of treatment, payment, or administration. What we have also advocated is that as we're moving substance use into good medical care, that we look to how we can increase the protections on sensitive information. The Genetic Information Non-Disclosure Act, or GINA, says that information about a patient's genetic information can be shared for the purposes of treatment without the patient's expressed permission, but it is not permissible for that information to be used for insurance, housing, education discrimination. I think that GINA actually doesn't go far enough for people with addiction or for other sensitive conditions. Inadvertent or advertent disclosure of information ought to be protected so that it cannot be used in civil or criminal procedure. If that information is disclosed, that information should be considered legally tainted and cannot be used.
Well, it's very exciting to hear that there seems like there will be activity coming out of SAMHSA, and I'll just mention for our listening audience as well that we will be posting a summary of the town hall that Eric mentioned and other related materials on our website alongside this interview, so we hope that folks will access all of those as well. Eric, one final question for you. Whether or not the Part 2 regulations related to substance abuse are modified, any thoughts on currently best pathways to exchange information that may include patient substance abuse information with care team providers?
I think there are two things well, maybe three things that healthcare teams, healthcare providers can do. First and foremost, it's really important to be consulting with a health information lawyer, which I am not, and I cannot give recommendations that are legal opinions. It is very important in this area that you talk to a health lawyer. Second is this mechanism that SAMHSA, that 42 CFR permits, of a qualified service organization arrangement or agreement, has been used and is being used between substance use treatment programs and community health centers, or between substance use treatment programs and hospitals or other healthcare systems, where what essentially is being done is to set up a contractual arrangement to provide information back and forth about shared patients. This works well for specific programs working with an ACO or working with an HIE, a substance use program. So the qualified service organization agreements may be one vehicle for permitting the flow of information. And then the third, and probably the most promising, and the one which doesn't require any changes to 42 CFR, is to bring the substance use care, the identification, diagnosis, early intervention, and treatment inside the healthcare team and inside the administrative organization of the healthcare system. If what we are finally recognizing is that the head is connected to the rest of the body, that addiction is a significant comorbidity that is associated with unstable hospital discharges, higher medical costs for diabetes, hypertension, and other conditions, and is itself a risk factor for a wide range of injuries and illnesses. As we are increasingly recognizing that the head and the rest of the body are connected, it makes sense that as part of a patient-centered medical home, as part of an ACO, as part of an HIE, as part of a health umbrella organization, that substance use care should be brought inside, not as a separate, freestanding, separate substance use treatment entity, but as part of good medical care. The same thing is being done with mental health care. The same thing is being done for STDs. The same thing is being done for smoking and tobacco use. We cannot improve the quality of care. We can't get consistent and better good outcomes for and value for resources expended if we do not bring substance use, mental health, and health together into a health home for our patients. And that really is, I think, the direction that the healthcare system is taking, and which I think increasingly is going to make 42 CFR Part 2 irrelevant, because the healthcare system is going to be recognizing and incorporating substance use treatment as a routine part of good primary care and also good acute medical care in hospitals and EDs.
Wonderful. Eric, thank you so much. This has been incredibly helpful and informative, and we greatly appreciate your time. So thank you very much.
Thank you.